So this is one of my favorite panels of this event, and being the moderator, I'm going to take some executive privilege to say that it was 4 years ago that Melissa's invitation to Arizona, and specifically this particular panel, kickstarted our conversations around what is now Contexture. And I think it's just power to show you that you never know what having those conversations and setting those tables is going to lead to. So this panel is one of my favorites. This is the Bold Horizons, the Future of Health Information Exchange, and I've got 3 colleagues and friends here from across the country who are going to share their perspectives of what's happening nationally in different markets and in different industries. So it's going to be a great conversation, and would really encourage. So the way we're going to do this is, as we're talking, if you have questions or something comes to mind, or you want to throw us a softball or fast and inside, just jump up, grab a mic, and throw them at us as we go through. So more conversational if you don't mind at all. So today we're going to kick off. I'm going to let everybody introduce themselves and their organizations, and I think I'm starting with Todd.
All right. Todd Rogow, and I am the CEO and president of Healthix, and we're located in southern New York. You want me to jump up and do the slides right now? Or do you want to do quick introductions and then do the slides, or just start?
Go for it.
All right, I'm just going to kick right in my slides. So here we go. I'm going to stand up because I like to look at people like a cat. So anyway, Healthix. So we're located in southern New York. We cover New York City, Long Island, and up into the state a little bit. And let's go to the next. Who has a slide clicker?
I don't know. There was a clicker at one point. Yep.
All right. Okay, about Healthix. So just a little bit about our mission and vision. So mobilizing health information across communities to advance patient care. So if you know about an HIE, we all pretty much have the same goals in mind. We're pretty similar from that perspective. Here's a nice visual. We represent over 2,500 legal entities. And out of those 2,500 organizations, that's over 8,000 facilities. So we do have pretty broad coverage. I've kind of broken it down into the different categories of hospitals, other regulated entities. Those are OREs. That's another acronym. That's probably a New York thing. Physicians that use us, CBOs, community-based organizations, behavioral health organizations. So we really try to cover the gamut in terms of your healthcare journey as a patient. We also do have over 20 health plans that are part of Healthix. And that combination of real-time clinical and claims data has really helped over the years, and I'll talk about that a little bit more. Here's some numbers just to kind of get you thinking. If you start with the 480 million inbound messages or data coming into us on a monthly basis. So these numbers are pulled from August of this year. And you can imagine during COVID, these numbers could have been higher. But we pull in a ton of information. We cover over 50 million patients, which you'll say that's impossible. New York only has 20 million. Well, we've got New Jersey, we have Pennsylvania, we've got Connecticut, and a lot of people like to come to New York, and unfortunately, they end up in our healthcare system. So we've been around for 15 years. We have not purged any data, so we probably have a few people who have deceased who are in our system. But anyway, we do have 50 million unique individuals within our system. I would say about 20 to 25 million of those have activity on an average year. So we do kind of see that normal turn. Now, we do push out a lot of data. So starting in the other corner, 15 million alerts delivered. These are real-time clinical alerts. Have to do with emergency visits, inpatient, outpatient. We have alerts across the spectrum, in and out of nursing homes. So we do push out a lot of alerts. During COVID, and we've kind of taken these back now, but we were alerting people on lab tests, so if they were testing positive or negative. And it really did make a difference. There were people who the clinician actually found out before the patient did, which is kind of interesting. But especially in the nursing homes, if you've heard anything out of New York, you may have heard of the nursing home situation. So it was very useful for the clinicians or the nurses going in to meet with the patients to know if they had tested positive, so they don't then carry that forward to the next patient. And then we also 260,000 patient records that are viewed in our clinical portal. So this is kind of outside of the workflow, but still people come to our clinical portal outside of an electronic medical record system or electronic health record system. But just as important, that 284,000 records that are in an Epic, in a Cerner, in an eClinicalWorks. And so we've, through the years, done more than single sign-on, but actually we're pushing data and alerts right into the clinical workflow, which I think is really important for clinicians, so they don't have to get up, look away, log into something else. So we move a lot of data around. I think from the last panel I heard it was important to be bidirectional in data. So data coming in, data going out, and this is our mission. Healthix services. So we've broken this down into 3 major categories. We have data retrieval, data delivery, and data discovery. And so we're trying to keep it simple and categorized at a high level. On this next slide, this is going to take some reading glasses, at least for me. But we have you can kind of see and get a taste of our services in these 3 different categories. So in our data delivery, we push out those alerts. See all the trigger events. There's a whole list of trigger events. We have a lot of them built just for public health. We do a lot of work for the city Department of Health and Mental Hygiene. We do a lot of work for the state and also the counties that we serve. We also push out a lot of data to data warehouses. So if you're a large IDN structure as a hospital, or you're a health plan, and you have the ability, the technical capability of taking in a large amount of data, we have something called clinical information updates. We can push that data out in real time in a very consistent format. And we get this a lot from our larger participants of the exchange, because they want the raw data, and they want to work with it, they want to deal with it themselves, they want to commingle it into their data set and make use of it. So we've implemented things such as that. And even for community-based organizations that may be low tech, we have a flat file format which we can push out the customers that they serve or the patients that they serve. We can push out the information that they need on just their customer base that they're looking for. Data retrieval, you can query Healthix. We get a ton of queries, as you saw. And we also have single sign-on, stuff like that, where you can basically pull. We have InsurTech, if you've heard of InsurTech. They're a data aggregator unto themselves. And what they do is, if you're going for life insurance or disability insurance, they will query Healthix for that complete record. And that just helps shorten the cycle of applying for disability or applying for life insurance. And just as importantly, it really saves time and money for these organizations as they're trying to gather your data across the community. And then data discoveries, gaps in care. So this is really big and important right now, just identifying where the gaps in care reside. And if you're a large system, you may know a lot about Todd, Rogow, the patient, but you don't know everything. And especially in New York, where you can just walk across the street to another large healthcare system, it's really can be challenging. Even when you're all on Epic, there are some gaps, especially in the ambulatory and behavioral health communities. So Epic is not everywhere. But we do a lot of work in gaps in care and analytics and research, and we do a lot of reporting services, so a lot of reporting for public health and the private sector. And then this slide, I left it in, is kind of interesting, and I thought you could look at it later, but it kind of shows the core of what we do in terms of data aggregation. We've got our services data and how people access. Then as you move out, you start to think about, when you're thinking about what do HIEs do, you think about the partnerships that we have. I think one of them here in Arizona is with Unite Us and one of the programs that they're doing. So you start to think about an HIE can't do everything. So you do it through partnerships, you do it through value-added services and partners that you solely outsource to. And really together, what we're trying to do is we're trying to kind of patch things together to really be that community kind of service as not only the pipes for the data bidirectionally, but how can we provide those services to really facilitate the work that you do as providers in the community. And then this is the big question. So I'm gonna show you my last slide here. So I won't bore people, but just the future of HIEs, and this is kind of my take. I've been in HIE space for about 14 years now. I used to help run the HIE in the state of Maine, which is one HIE for the state of Maine as a chief technology officer. And at Healthix, I've been the CIO and now the CEO for the last 3 years. But this is where we're really focused when you think about HIEs in terms of our sustainability and the value that we give to the community. So health data utility, that's a concept which we heard earlier on today. A lot of work has gone into that. A lot of our funding comes through the Medicaid office from the federal level through the state down to Healthix. Payer services, this year we implemented some new products around Alerts Plus, which are really more enhanced alerts that the health plans love to receive in New York. And also we went through last year, and we're going through it again, this process of curating our data. So NCQA has a supplemental, I forgot what they call it, it's a DAV program. It's to, you probably know what this is. Anyway, it's to certify your data that the data you get from the source will actually come out the other end of Healthix. So we're going through that again, and this is certified data which you can use in HEDIS calculations, which are the quality metrics that a health plan, the 5-star rating. So they can actually get more in reimbursements the higher the star rating you are. And then supporting research, we have a really big project kicking off of creating this huge de-identified data warehouse with the city of New York to support their research and investigations and public health, syndromic surveillance kind of stuff. So we're really excited about that. We're looking forward to tackling that over the next year. And we have been getting a lot of research requests over the years, kind of one-off. We actually have a chapter in a book coming out later this year, so we're excited about that. And then clinical trials is a large one that we've been working on. AstraZeneca has been kind of the lead working with us. We hope Pfizer will join them. But New York, with its diversity and its size, is really a wonderful test bed. And they see New York as a one-stop shop when it comes to some clinical trial opportunities. So that's something we're pursuing quite heavily. And then consumer empowerment. As we get into the Q&A, I want to talk a little bit about more what our plans are for next year. We hope to finish some technical integration work on the back end to really link up with a lot of patient apps to really engage the consumer. So up until now, the HIA has really been in the wholesale side of the business. We've been hiding from all you, the customers, the patients, the members, and just dealing with the clinicians and the care managers. But now we're getting into the business of actually interacting with you, in this case for us, residents of New York, and saying we want to first empower you by giving you your medical record. And then two, I would like that wonderful feedback loop, which I'll talk about later on today. But I think when we talk about race, ethnicity, gender, I think getting that directly from you, the individual, is going to be very, empowering. It's just going to help the whole healthcare system understand what are the challenges, how do people see themselves, because what I've learned is that as much as we collect this information today, it's not always accurate, and it can be better. So those are kind of my 5 anchors for HIAs in the future. I think that's it. Yep.
I think they've got to load you up.
They gotta load them up. Well, first off, hi everybody. I'm gonna just sit right here, lean forward a little bit, let the light keep shining on me. But my name is Honea English. I'm the president and CEO of Civic, the Center for Improving Value in Healthcare. We are located out of Denver, Colorado, so we support pretty much all of Colorado, as well as do a lot of interactions nationwide. So let me just go ahead and start off. We are celebrating this year our 10th anniversary of transparency. So we started producing public reporting, our first shop for care tool in population health reporting back in November of 2012. So it's a big year for Civic, and there's been a lot of activity going on throughout the year. So our mission very clearly is really to provide information that help drives and provides strategies for positive change in healthcare. And we do it through collaborative support services and health information to advance the triple aim. We do a lot for the quintuple aim now, as we like to say, as far as doing more for provider satisfaction as well as on the equity front. But our mission at this point is regarding the triple aim and our mandate from a statutory perspective: better health, better care, lower cost. We are a nonprofit organization, which differentiates us for the vast majority of APCDs within the country. There's only a few of us that are on a handful here that actually are nonprofits and operate outside of the state. So we are independent, and we work very, very hard to remain independent, bipartisan, and extremely objective. And I have to say, each and every one of our staff say the hardest thing that we do is to remain objective on everything that we produce and work on within the organization. We serve virtually every single stakeholder within the healthcare industry. And we refer to them as change agents. Our goal is to provide them information to allow them to develop those strategies and actions to drive positive change in healthcare. One of the areas, just to really highlight, what's not on here, and we should, is digital health vendors. That's one of our fastest growing areas. They support these various different industries or stakeholder groups. Also researchers. We work with a significant number of large and growing number of external or national researchers. So we're very, very proud of the fact that we have the VA in Rhode Island is able to use Colorado data because we make it available and they're able to correlate to their population and so on. Duke, Harvard, Rand, we're very, very pleased to be able to participate in a lot of multi-state initiatives as well. Just to give you a little bit of an overview regarding APCDs, because this is predominantly about HIEs and some of the interactions that occurs within HIEs, and a lot of people say, what is an APCD? It is an all-payer claims database. They typically, and each one is a little bit different, but more and more of the states are moving towards a common data layout, but it includes medical, dental, pharmacy, vision as well. And it's collected from both the private as well as the public payers. So we refer to it as our commercial payers, which also includes Medicare Advantage, as well as all the wide array of fully insured as well as supplemental plans that are out there, and the public payers, Medicare and Medicaid primarily. So some of the, versus when you're looking at just the blues, you're looking at just a single payer, some of the benefits when you're looking at across more at a population basis, and the more dense you are within the various regions, whether it's a state or region nationally, it's really being able to capture that longitudinal data on individuals. We do a lot of churn analysis. As people move from one health plan to Medicare, they come out of Medicare, they move into or Medicaid, then they move into Medicare. We're able to follow that individual across all of their different carriers that they may move in and out of. Patient data that, again, spans care settings, whether they've been a part of a specific health system or they go into an individual provider group that may not be part of an Epic system or whatnot. We're able to pull that information and provide to provider groups that supplemental information that doesn't reside within their actual data that they house internally. We get data from most all insurance companies and carriers within the state. And again, I also mentioned Medicare and Medicaid, but also self-insured. Legally, we're not able to, the states cannot mandate the ERISA plans, but we do have all of the non-ERISA, which is approximately 50% of the self-insured. Obviously, demographic diagnosis, reimbursement information, we obtain all plan paid as well as member paid information as well. Extremely useful for policy. Research, clinical and health performance, system performance, evaluation, pop health, et cetera. This chart is, or picture here is much different than what it was 3 or 4 years ago. So as you can see, there are currently 32 states that have some form of an APCD that's either existing or in implementation, and that includes the voluntaries. You see all those black boxes that are out there as well as the dark blues? Just a number of years ago, that number was 18, and now it's up to 32. So the states are definitely moving forward, and if you look at the lighter blue, a lot more states are right now under review and looking at putting in the statutory means and regulation that's necessary to go ahead and move forward. So a lot of activity because they are seeing the benefits, such as organizations as Civic and what we're able to do within the state of Colorado. APCD started in the Northeast. So they have the highest concentration. Obviously, Maine was one of the initial APCDs within the country, so a lot of activity going on. 6 critical functions of an APCD. I'll let you go ahead and look at these, but really, really important. There was a study that was done by the Commonwealth Fund And they looked at these 6 particular categories. Civic is one of 2 APCDs that operates in each and every one of them. And other states are really trying to adopt and work in more. But we're very, very proud within Colorado is the amount of work and the amount of effort that we have with and collaboration that we have with the various stakeholder groups. What makes Colorado different is that we are legislatively enacted. And this is really, really critical for a lot of the APCDs over the voluntary ones. The payers themselves say it's much easier for them if it's required by law. And within Colorado and the vast majority of APCDs that are out there, they are legislatively enacted. Also within Colorado, the legislation the statute is extremely broad. And regulation is what helps to define it more. But that made a big, big difference of Colorado over some of the other states, is that we manage very, very tightly to the framework of HIPAA, high-tech, antitrust. But other states have a lot of stipulations that basically, I'll call it the hand-wringing. So it's a lot more constraints on what they're allowed to do with the data. And fortunately, Colorado manages to the compliance and the requirements on the federal guidelines as well. We are a nonprofit that I've already talked about. Comprehensive and timely data, we receive information on a monthly basis, and we update our data warehouse bi-monthly, so every other month. Quality assurance. In the very beginning, Civic basically realized that they had a lot of quality that they needed to work on. We took ownership of the data from our data vendor from the quality front. We do data mining, we review each and every file that comes in the door, and we continually work with the submitters, and they work very, very well with us. It's a partnership to increase the level of quality and ensure that all of those gaps are complete and full. And so therefore our data becomes useful. We do a lot on the public reporting side. We have probably, as you can see here, 20 to 30. I think we're close to 42 this year as far as transparent public reporting. On the non-public side, this is where Civic also differentiates itself. And we'll talk a little bit more regarding as to what type of data that we release non-publicly. Within Colorado, we've got, within the archive data, probably around 250 million additional claims. But right now we have in our data warehouse right now through 2021, around 870 million. We'll be exceeding a billion in our actual data warehouse, and then plus what we've archived in the past. We have 36 commercial payers, Medicare, Medicaid, that includes Medicare Advantage. We actually were up to around 45 commercial payers, but as the market has continued to merge, buy up other plans, right now it's operating at around 36 different distinct payers. We represent currently 5 million active lives. We actually have over 8 million lives that are represented within the APCD, but that represents the inflow and outflow of population over the years. We have, I said earlier, we have around 1 million or 50% of the self-insured, which is primarily the non-ERISA. We do have a bit of ERISA on a voluntary basis, but only a few amount. We represent approximately 70% of the covered lives based on the medical. And then we provide for the vast majority of our reporting trend information going back to 2013. What is not in the APCDs? Anything that is not, that the states are not able to require by law. So all federal programs and the majority of the ERISA-based self-insured employers, as well as the uninsured and the self-pay claims, as well as a portion of the supplemental, and we'll talk about as to what supplemental information or APM, alternative payment models that we do receive. What gets submitted, as we talked about, into the Colorado APCD, we also receive monthly provider files, in addition what's addressed on here. We also receive vision files and supplemental claims as well. Non-claims data we get on an annual basis. So we have APMs, drug rebates. We are starting to receive this year value-based pharmaceutical contracts. We're basically a leader nationally, and a lot of other states are watching how well that goes. And then we have additional fields that we're collecting annually associated with our PDAB, which is a new statute or bill within the state of Colorado, in which they're looking on the top 100 or so pharmacy or drugs within the state looking at ways to bring those costs down. Those are the specialty drugs primarily. I did want to talk a little bit about what we collect as far as and able to report then on health equity. We do have race and ethnicity. We also do have extra fields regarding non-binary gender. Those fields are pretty light at this point as far as those that are filled out. We'd also started collecting language barrier, and again, that'll be an evolution and a progression as to starting to collect better data. And then, of course, Z codes, which have been a part of ICD-10 that we've implemented a number of years ago. That data is actually really starting to grow as far as more and more providers populating and utilizing those diagnosis codes. And again, I'll just go ahead and end a very, we again look at, we call our custom, but though we do have standardized, so we have our non-public information, and then we have our public. We offer custom reports. We do a lot on the analytics side. We also have developed standardized reports for provider groups, for physicians, for employers, hospitals as well. And then custom data sets. We do fully insured, limited data sets, de-identified custom data sets, as well as our standard de-identified data sets as well. Both the standard data sets and the standard reports are as a means to increase access to the information at a much lower cost. We also have what's called a data release and review committee. Any PHI that walks out of our organization goes through an external committee to ensure minimally necessary is being utilized and that we are strictly abiding by not only HIPAA guidelines, but also antitrust as well. On the public side, we are very proud of the amount and the types of information that we put out publicly. In the beginning, it's, well, the more public information that we give out, the less value that we're going to have on the non-public side. But the reality is the amount of public information that we're able to release, it is very much at the population level. We have community dashboards. We just rolled out a brand new affordability dashboard. But the community dashboard, we used to have quality reporting, outcomes or chronic conditions, healthcare costs, et cetera. And now you can look at it by your counties or your specific regions and see all of your information. And we also have social determinants of health that we've just brought into our community dashboard as well that we're very proud of. So, and I'll leave it there.
My name's Sarah Miller. I'm an expert associate partner at McKinsey & Company. I did not bring slides because Morgan told me that we were the last thing between you and the happy hour, so it seemed like in everybody's best interest not to do that. At McKinsey, I do all of my work with Health and Human Service state agencies and their partners to make the ecosystem of government easier for people who rely on the necessary services that government provides. That's given me the privilege and opportunity to work with a number of state Medicaid agencies to help them develop partnerships with their HIE partners. I have worked with a number of HIEs across the country to think about what's the financial sustainability model now that the CMS has changed the federal funding stream for HIEs. And I'm pretty sure I'm really on the panel because I have a large number of opinions about most topics. And so when they wanted to have somebody to chatter, Morgan said, I think you should invite Sarah. So here I am.
Wonderful. So again, just a reminder, if you have something top of mind or you want to dig into something that any of our panelists have brought up, please just step up to the microphone at any time and we'll get you in. So I have my notes here. I'm not going to check the pictures of my children eating ice cream in Denver right now. Where'd it go? There it is. Okay, so can you each just take a couple of minutes and tell us your insights or your thoughts about this growing concept around the health data utility, Todd, that you brought up. The need to continually incorporate new and different types of data into different types of products and services. And what are you guys doing in this regard inside your own organizations? Or Sarah, what do you see growing across the country?
No, please, Todd.
Yeah, all right. I'll kick us off here. So there's a lot of activity in New York on this right now. First of all, I would say that just from a funding model perspective and how we work with the different levels of government, mainly being the state and city, and in my case, some counties, they have heavily supported us financially. So we've always had that kind of exchange of data even before the pandemic about different types of reports. They wanted insights into the population. Now, New York is a complex state. When I joined, there were 13 HIEs, and now we're down to only 6. Healthix is certainly the largest, but the biggest thing on our radar right now is what's called an 1115 waiver from CMS. So New York is in their second draft. It's only for $13.5 billion, so a little bit of money. But the wonderful role that HIAs will be playing in that is to be the backbone for moving the data around, and specifically the outcomes that they're looking for is really focused on equity issues and social determinants of health. So a lot of focus on referrals and collection of health assessments. And this is all focused on the Medicaid population. So for me at Healthix, representing downstate, if I just picked on Brooklyn for a second, Brooklyn, and I didn't realize this, but 50% of Brooklyn alone is on Medicaid, which is crazy. I mean, if you go to New York City and you just walk around, you don't necessarily think that, it costs a fortune to live there, by the way, to buy any real estate or just to live there. But half of Brooklyn, people in Brooklyn are on Medicaid, 40% of the Bronx, Staten Island about 40%. I forgot what Manhattan was, but it's just astounding. But the Brooklyn population on Medicaid is 27% of the statewide number for Medicaid. So this waiver is a big deal for us. We hope CMS will approve it. And again, this is really going to bring extra attention and monies, which are really needed to build up the infrastructure around collecting clinical and social determinant of health information, really from the ground level up, working with community-based organizations, behavioral health organizations, leveraging the HIEs to kind of funnel this up to the state for monitoring and oversight, but more importantly down to the clinicians and to the nonprofits or CBOs who are actually serving these people. So we're excited about that.
Okay. So we have a wheel, so we say, okay, what would be a complete picture of data that we need? Because we're dealing with retrospective for the most part, but we're updating the data warehouse every couple months. So we're dealing with 4-month delay as far as the data actually coming in the door. But when we looked at where our gaps were, so we have fee-for-service data initially. Then we started bringing alternative, basically the annual fees as far as drug rebates and the APMs, different incentive payments, the capitation, et cetera. So we wanted to make sure we've got more of a picture. We now are just bringing in premium information, because again, that is a part of healthcare cost for the employers as well as the consumers. And then we work with a lot of researchers on other supplemental data, and so we bring in vital statistics, death registries, birth registries. We have certain processes that we work on with the state to be able to do matching on that data and to be able to release the information. Registries, we do a lot as far as the cancer registries and the immunization registries, et cetera, again, on very specific, case-specific, request-specific, according to our release allowances and so on. So we do a lot of work from that side as well. And I think, the goal for us is how do we work through all those statutory requirements so that we can bring more of that information in without all of the process and some of the struggles that go with it, because every single department, every single registry, every single other type of data set has their own types of policies, restrictions, statutory requirements, et cetera. So it's a big challenge for us as well. The one thing that we're very excited about is some of the work that we're also doing with Corio, as far as how can we go ahead and blend together and work specifically with real-time as clinical information as well as the retrospective administrative claims data. And so there's a lot of efforts that are doing as to how do we go ahead and make that work and work well. The other thing as well that we look at is, okay, how do we enhance the data? So it's not just the claims data or the APM information that's coming in, but looking at enhancing the data in the form of grouping therapeutic classes on the drug side so that we can do greater levels of an analytics, also looking at risk assessment, risk scores, and so on.
I think from the chair I sit in nationally, as HIEs consider their future, the value of the investment that has been made and is not inconsequential when you think about the hundreds of millions of dollars that CMS poured into many state HIEs across the country. And so for me, health data utility is about taking that investment and leveraging it for broader purposes while determining financial sustainability models that make sense. And so I think as we look across the country, HIEs are looking to figure out what are alternative data sources that they can get in. How can you have more data that provides additional value to either your state government counterparts who are very interested in utilizing data to inform policy decision making, or to fee-paying participants who frankly probably don't want HIE custom reports. They just want the feed that they can suck into their own population management systems where they think they can do stuff better maybe than an HIE can individually. And so as I think about sort of a bunch of the topics I've heard here today in the room, particularly focused around social determinants of health, CMS calls that health-related social needs, right? So what are the things in addition to traditional medical care that members either in Medicaid or Medicare need, and the racial disparity information that we heard about. At McKinsey, we did a study where we interviewed a bunch of people of color and asked them about what they wanted their healthcare stakeholders to know. And some of this I think is very interesting. 5% more Black people than white people report that their race is likely to influence their choice of healthcare. 44% identify that they would avoid a care situation because they didn't think the place would treat them appropriately. Latinos report, 1 in 3 Latinos report unmet social needs, right? And so the things that we all take for granted to be happy and healthy and successful, people of color don't experience. And so then when you take that experience and you leverage it across sort of what that does to the healthcare system. So we know right now in 2022, $67 billion of medical costs are associated to health inequity in the country. And it's growing on a 10% year over year. And so that means in 2040, that number will be $210 billion of healthcare costs associated with health inequity. So the system, we collectively, everyone in this room, needs to be super motivated to figure out how can you better meet people's health-related social needs? How can you leverage, for example, your HIE partners to take all the data that exists about Sarah Miller in the ecosystem and make sure that I can put the most comprehensive care together? Because in the absence of that, like the healthcare cost continues to grow in an unsustainable way that is just going to bring the system to its knees. And so for me, health data utility is about how can we continue to leverage the investment that's been made? How can we take the data in its richest form that we all have high confidence from a data governance and data ownership is being treated appropriately and protective, but use that to generate better health outcomes for the people who need it the most?
So as you work across the country, who's kind of leading the charge on this? Who's doing like the biggest, best, coolest
New
stuff?
York, no.
It's totally Colorado and New York, right? That's got to be the answer. I mean, I never like the sort of ultimatum of best. I'll share some places where I think folks are pretty innovative. I have held that here in Arizona, the work that Access and Contexture are doing relative to community information exchange and actually using the HIE to be the vehicle of CIE. So community information exchange, for those who aren't familiar with the term, is like the social determinant of health add-on to HIE that connects traditional healthcare ecosystem with community-based organizations. I'm doing work in another state where they're actually picking a network of network approach to CIEs because all the payers have made national investments in community information exchange solutions that they're very invested in for their own reasons. And so in that state, they're saying, hey, we're not going to pick one like Arizona did, but instead going to connect and use data exchange across multiple competing, frankly, competitor technology solutions for the benefit of the ecosystem. And I think that's super innovative. I think the other trend that's happening is it used to be that every state wanted to be their own HIE and be all things to all their people. And I think kind of the shared service model, so the folks at CSRI and the consortium are really pushing the envelope in, like, if you in Colorado have particular expertise in master data management, is that a solution that you could offer to others and take advantage? So we don't have to build things, 50 times in the country, and be able to leverage in places where there are great success. And so I think that's how I would pick.
Nice. So what do you all see as kind of the biggest challenges to this industry or this work as we're going forward thinking about the future?
So there are a couple of challenges, I guess. They're different. One is I think technology is great actually these days. It used to be that technology was the problem. Is like we wish technology would only do X. I think we're actually at that point where technology can do almost whatever we want. It could always get better, but it's not that. I mean, at Healthix we have all sorts of technology from low tech to super high tech for integration, and the challenge I see is the clinicians and the administrations of those organizations getting it into the clinical workflow and making use of the data. And it's not just data, it's supposed to be information, right? It's supposed to be something actionable that the clinicians can act on or the care manager can act on. That's really where the rubber meets the road. It's like if you don't make a difference there, then all this money, all this effort is really just wasted. So that's where we're focused a lot of our attention is, are we actually making a difference? Are you leveraging the data to be information that you act on, and looking at that, the feedback loop that comes around, hopefully from that whole process to improve things. And so that's one of the challenges is how do we impact that kind of front end? And then the other one is this weird competition, and I'll just highlight this because in the HIE space, Epic wanting to be a QHIN under TEFCA, and in my local, community of little New York, we have IDNs who have their own HIEs, and the good trend there is they're giving them up and they're relying on Healthix, so that's positive. Because why would they spend the money and why not spend it on hiring nurses to actually take care of people? But those health plans, we have a health plan that has an HIE and EHR vendors who are acting as health information exchanges. Is that a good thing or a bad thing? And I don't know. I'm biased a little bit in this answer, but I just wonder if that's the solution that we're looking for. And they do have an edge. They have more money and more people than I can ever hope to have as a nonprofit. And is that the right thing? Is everyone going to use Epic one day? I don't think so. But it's kind of interesting. Our HIE is just a bridge strategy to get us from A to B, and then the private sector takes off. And okay, we've got it from here. We're going to make money now, and we've captured that value. Or can HIEs actually do that? And that's kind of a big question in my thoughts.
Well, and what we see a lot of is we believe wholly, and I know that Melissa talked earlier and Morgan regarding RICs, the Regional Health Improvement Collaboratives, that healthcare change must be at the community level. Their needs, whether it's social determinants, whether it's their provider network, the makeup of their community population is all different. And so their needs are different. And so change has to occur at the community level. And what we're seeing as one of the challenges is there's a lot more activity that is now feeding up to the federal level, because you got researchers and others that are really wanting access to data at a much greater level and a much easier level. And so there's a lot of push. But what happens, for example, like the RAND study, which is great, it's awesome. We've participated for the last 4 years that they've had it out there. It is an unbelievable study that was initiated by employers out of Indiana, and it's grown to over 30 states that are now participating. We were one of the first, if not the first APCD that participated with them. And the reality is that you get this minimalist, issue there, or result is that, whatever is the best data at the lowest level, you throw everything else out. So we've got to really, really make sure that everything that we're doing, and the challenge is as we get more federal programs going on, is that we are servicing the programs and the needs at the community level. And that's probably our biggest challenge. And that's the greatest amount of work we do, is the collaboration and the communication and working with those communities and making sure we're supplying data and information in a manner that they can put those strategies and actions in place to drive change.
Melissa.
I realized I needed to stand up or all my questions kept on getting usurped by the moderator. Okay, so this is, it's a follow-on to the challenge question. If you, each of you had a magic wand, what is the one thing that you would solve in the interoperability space? And my context for that is, I love the model of health data utilities. I love the idea that the information and the interoperability and the exchange we've done with clinical data and HIE can be translated to other data sets, but we do run into a variety of challenges when we start to bring those data sets together, integrate them, and try to do all these cool and innovative things you've talked about. So with all the different challenges that are out there, if each of you had a magic wand, what would you fix?
So I think we're supposed to read back the question. So if you had a magic wand, what would you fix with interoperability? If I had a magic wand right now, I would order a smaller chair.
I know, I can't sit back because I can't touch the Morgan and I did the same thing.
Oh my goodness. I think it's perfect. I don't know. I'm okay.
I'm going to start with that right now. And it's not, there's solutions out there. It's just the time and the cost and the energy to do it. We need indices for patients, providers, employers, that allows us to go across systems, you know, so we have an initiative that's going on, but there are so many hurdles. If we could just get rid of the complexity or just get out of our own way and just agree to utilize whatever system, whatever vendor, and you know, Melissa, you talked about it as far as the initiative within Arizona, but what's gonna tie all the data together from an HIE, the vital statistics, all of the state-related data, et cetera, is if there was a common indice to associate it, a person on English across all of these various systems, and just put it in place. The solutions are out there. It's just getting it done.
I think for me, it's the process of standard adoption that I find really, really painful. Like, as we started to talk to our clients who want to do a network of networks of CIE using social determinants of health information, we say, but there's no national data standard yet. There's lots of them evolving, and it's coming along. And then the lifers say, yeah, just like in HIE, where we've spent the last 20 years setting the data standards for how we're going to exchange health information. And so, you know, I think people see the value and benefit of data exchange. And so my magic fairy wand would make standard setting happen faster and then integrate it into the technology, like with a snap.
I've got a number one for you. So, you know, so I was up in Maine for 5 years running the HIE, you know, on the technology side. And what was wonderful about what they accomplished in Maine was it was voluntary. Unlike New York, which is required, you're required to send your data to the HIE. Maine is voluntarily set up. And what was nice about that is that the systems got together and it started with the hospital systems. Now, unfortunately, I don't think the plans are playing in, but from the provider standpoint, they all share their data openly. And they agreed to not compete over the data itself, but on patient outcomes, quality measures, you know, how they treat their patients. Normal businesses, you know, where they would compete over that. But what I'm seeing in New York and across the country is, and I'd like this to, you know, get waved away, is this competition over, if I hold on to my data, you know, it's my special sauce, and I'm gonna, you know, crush my competition by holding the data. And I really want to change that paradigm to be not about the data, because data needs to flow freely. And I think you know, what we're trying to do with empowering people and getting their data and taking it around with them is try to, you know, free up the data itself. And I think that'll really change things in healthcare.
But I think, you know, back to the challenge part of responding to that magic fairy wand is, I mean, data governance is the next generation of the things that have to be solved, right? Yeah. Like, I mean, the number of HIEs that I've worked with that have very explicit processes for making sure that a use case is actually going to be permitted in their participant agreement, and how do you go about governing it? And then, like, when you think about here in Arizona, like, there are tribal partner nations, right, who own their own sovereignty over their own data like they're a whole country. And when you think about the special nature of behavioral health data or SUD data, and what are the protections, and what do people have perception of consent relative to those things. And so I think in order to make all of these things that we're talking about with Magic Fairy Wands happen, like the next innovation in data governance and who's going to have the right model to say, this is how you balance protecting people's privacy, because that matters conceptually until I understand that if I say I want it to be private, that means my doctor isn't going to have the information when I go. That's also super annoying to me, because my aging father has to call his daughter who lives 3 states away to get the record release transferred when it could just go in the HIE, right? And so I think people don't even understand what they're preventing by holding the integrity of privacy most sound.
Well, and I'm just going to head on to that. So, I mean, and this is what the issue is, I think, for a lot of the different states, is because it's hypnoia. I mean, imagine the little face that's go at the top. We can give a whole, class day. Annie's here, but we can definitely talk about HIPAA till it's in the moon. But literally, HIPAA has a significant amount of allowances, but so many organizations and states, and they use it as a crutch, whereas if we use it as a framework, HIPAA, high-tech antitrust, high-tech's not even around, but antitrust, the allowances are there. Right. You just have to know what they are and not use them as a crutch. And so I agree. There is so much that goes behind, the wall with the eyes peeking out, that basically is saying we can't do it, and we got the hand-wringing going on, when the reality is understand what you can and you can't do and have that be the framework. So.
Exactly.
Well, my magic one is broken because this chair is getting bigger. Serious, this is ridiculous. So
do you want to stand?
We've got about 4 minutes left, and I want to make sure that nobody has any questions from the audience, because I just made up these questions, so I don't want to assume that I'm asking the right thing. But a lot of folks in the room are HIE participants.
I was gonna ask the audience a question.
Okay, ask the
I'm
audience.
just kind of curious if we only have a few minutes left. This is more for what I'm about to do next year in New York. But how many of you have health apps on your phone where you can access your clinical records? The large majority of you. How many of you actually use them? Because I know some come preloaded. So, okay, that's great. It's just I really think this is the future of what will change healthcare, is through us as consumers actually making that change. So thank you for that. I just want to do a little poll.
No, you're good.
It used to be only 10%, so I'm glad that it's increased, at least in this room.
And I would assume that most people have access to the Apple Health app that's got all of your records in there. And I'm sure that the marathoners in the room are using something that costs money every year. For the folks in the room that may be users of the HIE or thinking about it or working with us in some degree, what are some of the cool things that you're seeing happening out there in the rest of the world where that partnership is really working well for folks, where they may be doing something really innovative? I'm just really curious to hear kind of what's on the bleeding edge out there that folks in this room could leave thinking about.
I'm always looking to remove barriers to getting people access to care. And so my friends in Maryland, my favorite use case that they do is state Medicaid agency contracts with federally qualified health centers to provide prenatal care to mothers who don't have a primary care provider assigned. And so the HIE in Maryland, for every person whose record comes with a new HCG positive lab result, that Medicaid individual gets checked against the roster to see if they have an assigned primary care provider. If not, their demographic information gets shared with federally qualified health centers, and the case managers at the FQs reach out to try and provide early prenatal care to those mamas. And I think it's been around for quite some time. It's not super innovative, but not enough HIEs in the country are doing it. So please have a conversation with your Medicaid agencies about getting prenatal care for your Medicaid members.
Nice.
Something innovative? There's so many. No. There's one project we did last couple of years. It was with So New York City has a different relationship in terms of school children's health. They're actually directly responsible for the 5 boroughs. So that represents about 1 million students on an annual basis. So what we did is, because of protection of school, children's data, we presented those in that age to the city, and they said, yep, we've got a good, I think it was like 97% match. We said, okay, great. What we were able to do over the course of the next 8 months was supplement the knowledge from a clinical standpoint of those children in the schools to those school nurses. They were focused on things like asthma, depression, anxiety, and we were able to highlight and identify, more students. Of course, now that puts a greater burden on those poor school nurses who are just losing their wits about it because of COVID and everything else going on and too much. But this just shows a wonderful example of how data can really empower and inform. So now the City Department of Health and Mental Hygiene can say, hey, look at this. Potentially we need more resources. We have better knowledge of what's going on in the schools. And I was really thrilled to have that happen. That's 1 million lives. That's not a small project when you think about it.
So there's tons of stuff that's going on, especially with a lot of the researchers, but one in particular is that most of you in a lot of the communities have the organizations that are providing nutritionally based meals based on the type of chronic condition that they have, whether it's asthma, cancer, diabetes, et cetera. So we did a study with Project Angel Heart, and there was a number of organizations involved, but we did the study that said, okay, of these, we took their client base, lumped them into the various types of chronic conditions, and then we took control groups within the APCD, and we looked at before care, during care, and after care. And some of it was just for like 4 or 5 months that they provided the care, and then we looked at, okay, what was the impact of total health or cost compared to those with very similar chronic conditions that did not receive these nutritionally sound or based meals, and what was the difference over a period of time to their total healthcare cost. And we were able to show out of 9 different chronic conditions that we isolated, few we had to throw out because there wasn't enough of goodness, so there was around 4 of them that showed very dramatic improvements in the overall cost, because these patients, upon either before they went into the hospital or right after they got out of the hospital, they received for a period of time the right type of food, 3 times a day, every single day, for however many months that were prescribed. They were funded primarily by donations. And it was just from the goodness of people's hearts that they were providing and able to provide these meals, as well as tons of volunteers. They then were able to contract with Medicaid. They were able to get contracts in place with a number of the health systems as well, especially those that were on capitated models, that it really made sense for them to go ahead and provide these meals. And so now Project Angel Heart is, I believe, statewide, and they now have contracts in place from a number of different organizations that allows them to do much, much more for many more chronic conditions as well.
So I ran through all of my questions already because I anticipated more conversation from the audience. You guys are making this harder on me than it's supposed to be. So now we're shooting from the hip.
He's looking at you.
Are you looking for me to come up? I've already surveyed them. I can't do anything more. No, I don't know.
Maybe I'll share, I think this is a unique opportunity in time, because what COVID did for HIEs in many states was to change the orientation to include serving public health in a meaningful way. And I think it really changed the value proposition. And so as we think about a future where it feels like maybe we're just gonna go from one pandemic to another, it's really interesting to think about that core function and the things in which, public health has always cared about everyone in a geography. And so, HIEs that really relied on Medicaid, and you might have 25 or 30% of your state's population that was Medicaid covered lives. Now, when you can serve a public health agenda, it really broadens to all of the lives in a place. And so I think about continued partnership with public health, and you heard the public health professionals right before us talk about how much data need they had. And when you think about, sort of what HIEs hold in terms of available data, like it feels like there is a marriage still to be had there in terms of value proposition. And some of the innovations I think in the country are places where public health agencies are relying on HIE network of pipes to all these reporting providers to actually reduce provider burden by making their public health reporting through the HIE pipe instead of in a standalone process and system. And so I'm all for helping the public health people too.
I totally agree. And so I sit on the Medical Services Board in Colorado. It's a board that reviews and approves all of the Medicaid policy. And now we're starting to talk about the rolling back of the public health emergency.
Yeah, the public health emergency.
And I think that, we learned a lot, good and bad, over the last 2 years. Earlier in a different breakout session, we heard about, this huge transition to virtual care and telehealth and telemedicine. But I do think that's going to be really interesting, and we should be very thoughtful about what we roll back from the public health emergency going forward, and making sure that we don't disregard those lessons that were learned for the good. I mean, I think that, from a consumer approach, I would much rather have the ability to have that virtual visit than drive all the way across Denver to go see my PCP in order to get the medicine that they already know I need.
And you have a living wage and don't have to work 3 jobs in order to support your family, right? I mean, that's, I think, the gift of telehealth for a Medicaid-eligible population, right? Is no longer does it take me half a day to have my primary care visit, but I can take it on my own phone, in my car at my work if I have to.
Yeah.
And I think that policymakers are pretty serious about keeping some of those policy changes that have resulted in such clearly better outcomes for members. I think you'll see that continue nationally.
Hi. As you talk about innovation, is AI and machine learning coming into play and being leveraged, and if so, how?
So the question is, how is AI coming into play in the work we do? It is, and we do predictive analytics. We actually used it in that city program to help identify the student population who were at highest risk of coming down with some of the conditions that they were looking for. So we've used it there. I would say, for us, at least the requests upon Healthix, people have tried to use it more on the public health side, which is interesting. I feel that the health plans already say, hey, here are your high-risk populations, go focus there. And AI is, for us, just adding to the pile of what the providers need to do. And I think the payment model has a lot to do with it. I think AI is going to become more important as the payment shifts from fee for service to something more, because there's not a big incentive to reduce your number of images you take or to reduce your lab tests. People make money off from this stuff, and there's a lot of money in healthcare right now. So I think the bigger change that will help AI take off, because I think there's a lot of potential there, is really payment reform. Something needs to change underneath before things really start happening.
And it's all, transparency is the big word, but what actually is transparency, and is literally getting the information out there. And so, in AI, there's different forms of predictive analytics and just base analysis, whether it's pop health or it's very specific payment. Just alone with the RAND study and some of the analysis that we do comparing commercial rates to, Medicare rates and then Medicaid rates in some cases, it really opens the eyes of the need to go ahead and make some very specific changes. Also, and taking into account, where a lot of the practices are, well, my population is sicker. So it's really important to put risk scores and risk analysis in there to kind of level that out. And that's all part of a lot of the work that's being done right now. More analytics than maybe true AI, but there's a lot of that's going on that creates value to dispel some of those concerns that, hey, we're not really looking at things apples to apples, and there's quite a bit going on.
Until we figure out how to get clinical data not in the form of a PDF, CCD, we will we will not realize value-based payment methodologies in the way that Todd's talking about it. And so for me, AI in the future, as it relates to HIE, is the big unlock of how can you really get that clinical data in a form that something can be done with it, whether you're the actual provider at point of care or you're the business manager trying to justify the investments that your providers have made and the time in which they've treated patients. As long as we're producing PDFs, we will need AI helping us get something out of them.
So I believe that you were here first.
Yeah,
on this.
maybe.
Okay.
2 questions.
So this question is for Anna. That slide you had about the all-payer claims throughout the United States, I noticed Arizona's was in the worst category.
Of nothing happening right now,
Yeah,
yes.
why is that? Do you know why, or who would be behind implementing that here?
So we work with a lot of different states, and we are part of NADO, also the National Association of Health Data Organizations, and they manage the APCD Council, or at least facilitate it. And so we work with a lot of the states that are thinking about it and looking at it. And a lot of it is really as to, on the legislative side, first off, is there within the state someone that's going to carry that banner forward and push it throughout the legislation? So, and there has to be, I guess, enough it has to be elevated enough within the state to say, yeah, we need this data. And it just maybe has not been a priority within Arizona that to overcome what you have going on at the border, or who knows what. So it's all about priorities within each of the states, and have they heard it enough and listened and seen what other states are doing that they say, hey, we want the benefit too. And so that's what you're seeing with now those 32 states that do have some form of APCD in the works. And you saw all those light blue ones, that there's a lot of states that are really, really working that legislative front. But it takes one or actually several stakeholder groups to really carry that flag and push it. And it takes work.
Thank you.
And this is the first time, I believe, in history that there's actually federal funding available to support the development of.
It finally got appropriated, or it's about to be appropriated in this next bill. So yeah.
You get the last question. She's waving a flag at us, so we only have 5 minutes left. So
Great. Before the PHE dropped life expectancy, the opioid epidemic was already doing that. So in that context, just curious what's going on nationally with Part 2 data and transparency around that. How the rest of you solving that conundrum?
We do a lot of drug analysis, I do have to say, a lot specifically on opioids as well.
I mean, I think nobody has figured out what the next generation of 42 CFR Part 2 is going to mean. Like the things that Anna and I were talking about earlier about, do people really understand what they're preventing when they say they want that information protected? Or do organizations who have the information even really know whether their information is really that information as a covered entity or not? Most of the time, they self-report that it is because they're too afraid, or their lawyers are too afraid of what might happen, and so it might not even actually be covered. I think the national conversation is very difficult to peel apart, because in the polarization of the country, people's perception of privacy and how up the backside of my life should government get to be. And even if an HIE is a nonprofit entity that exists in a healthcare ecosystem, when that kind of policy is being legislated federally, it's hard to imagine in the partisan nature of this country right now that there's ever going to be agreement, at least in the chair I sit in. Not speaking for my firm, please. Nobody call a partner at McKinsey and say I said this on a stage. But like I can't imagine that meaningful reform is going to happen there until maybe what Todd was talking about, like if consumers really get empowered and start to say, this is what I want with my data and it's mine to own, like maybe if there's that uproar, but in the absence of that, I have a hard time imagining that the policy is going to change substantively. But there's an expert in the room.
The
who
lawyers
can
have to
school
stand
me
up
on
and just
this.
add. It's worth noting that the CARES Act, which was one of the largest stimulus packages that was passed at the outset of the pandemic in 2020, contained a provision requesting that Congress requesting that the federal agencies that oversee substance use disorder regulations try to align to the greatest extent possible with the HIPAA regulations. What that means practically for us is that after 2 or 3 years of waiting at this point, we are finally expecting to see an updated regulation. It is sitting right now at the White House Office of Management and Budget, the OMB, and it will be released within the next 60 days. It will be the first significant change to the Part 2 regulations that we've seen in 4 to 5 years, but more importantly, it will contain an expansion. We don't know what it will say yet. We haven't seen any of the text. It's still embargoed, but there is some hope for those of us that live in the
Annie, I
difficulty.
love that, but I have to say you started by saying Congress requested the federal agencies do this.
Yeah. No, I mean,
as evidence of my
yes.
point. So I will hold
Yeah.
your hope.
No, you're right.
And we can talk about in 60 days how hopeful we are
So-
collectively
But
once
we'll
the
at
reveal
least see
happens.
some
doing
change.
who are hopeful.
Yeah.
Because really what it impacts is Medicaid. I mean, I think we've got around 26% of the
Yeah.
Medicaid, or at least within Colorado, that some portion of the data is being held back because it's basically got some piece of, and they don't release any of it, that doesn't have anything to do with it. So it is an issue, not so much on the commercial side, but definitely on Medicaid. And what we're doing is we're working with all the submitters, because we operate as a de facto covered entity, is to say, send it to us, mark it. We added in this year an indicator so that they can go ahead and mark that this is one that falls under 142, yada, yada, yada. And then we will, upon the release of the new data, or the new regulation, then determine as to how it can be released. And so that's the challenge.
Cool. You
because
gotta have it
because
before
it
you can
takes
release it.
time to change the historical processes. So we've already started doing that,
That's
but
great.
it will take years before it will get all opened back up again.
So I fully recognize at this point that I'm sitting between you all in the bar. And so I would highly encourage you all to visit with our friends up here. They traveled from far and wide to be here. They've got great expertise in their respective fields. I had one other thing that I was going to say as well. Oh, just to give a little plug for Civic, if you would like to go out and see what an APCD does, Civic's website is fantastic. It's www.civhc.org. You can actually go and look at their transparency reports and their public reporting.
you.
It's really, really, really cool to see that data in action.